All right, family. Hello. This is Dolly England, your PE 46 coordinator, coming to you from the Portland State Building on this, I think, cold and gray day. So, welcome to your November PE 46 webinar. This month's webinar is entitled Only You Can Help Increase Cancer Screening Ratings, or rather, rates. All right. So, for today's agenda, we will do some welcomes and introductions. We're going to talk about everything PE 46. We'll have some general updates as well as a fiscal update for you. But the majority of today's webinar will feature the ScreenWise program. And finally, we will wrap up with any questions that you all might have. So to get us started, as you all know, I love doing live polling, and this webinar will be no different. So to participate via Poll Everywhere, text PE46 to 22333, or you can participate from the web at pollev.com/PE46. This is a sample of what participation might look like via your phone and also the web. Here is another view of what said polling might look like. So let's try some practice polling, shall we? Let's do a little bit of a roll call. So for your first poll, using one word, tell us which county you represent. This is a word cloud. So using one word, tell us which county you represent. We'll give folks a second to chime in. There's no one out there? Folks having problems with the polls? Seems like we might have some polling problems. Oh no. Okay, sorry friends that my poll is being weird. That's disappointing. We'll try the next one and see if it works. Tell me one thing that you are looking forward to today. Will this poll work for us? This is very disappointing, isn't it? Okay. Looks like we're having a little bit of technical difficulty with some of our polling questions. So we will try to work to address this. But in the meantime, I'm going to ask this question. Oh, okay. So ignore it until we get to that ScreenWise question because clearly something has happened and I will figure it out. Thanks, folks, and thanks for chiming in and chatting. We will figure this out. So, just out of curiosity, if you want to type in how many people have checked out the PE46 training needs survey, you have received this survey twice now via email. And I can tell you actually how many of you have taken my survey, not very many. So as of this morning, 10 of you have taken my survey, and that's totally cool. I really appreciate it. The topics that have risen to the top are working with youth, data, how to integrate diversity, equity, and inclusion into your work, what is reproductive justice, and working with Latinx communities. So I just wanted to reiterate that the reason that I have this survey up, and I will leave it open for another week if you haven't had time to respond yet, is because I am not doing these webinars for me. They are for you, and I'm only interested in bringing content that you want to learn about. So please take the PE46 Training Needs Survey if you haven't already. Additionally, if you are doing any of these things in your own community and would like to share, please contact me, as I would love to have more sharing amongst PE46 coordinators on these webinars. All right, let's get into everything PE46. And that is what I'm going to formally call this section of my webinar. So, some general updates for you. Again, if you haven't yet completed the PE46 training needs survey, please complete it as soon as possible. I have sent out an email with information about technical assistance phone calls as well. All of that will take place in the month of December. This is 100% optional. It's an opportunity for us to check in, for you to ask any and all questions, or perhaps one of my most favorite things, Brain Jam, which is where we just brainstorm ideas for whatever you were trying to do. Additionally, if you're interested in scheduling a PE46 TA call, please see the email that I sent last week, or you could just send me an email. I will resend the TA call information out early next week when I send out our November webinar information. Our December PE46 webinar topic is data. So this webinar will be more interactive than previous webinars, as I'm going to figure out the audio and let you all finally talk. I want to first, I want this particular webinar to be the first of a series of data webinars where we learn from each other and identify ways to not only use data, but also gather data while doing PE46 work. Data to me feels like a whole lot of jibber jabber, so I will be on this learning journey with you. As always, the PE46 webpage is available to you. We have all previous PE46 webinars posted there, along with slides. So if you or someone from your organization would like to watch previous webinars, they can be found here. Today's webinar will be posted within 7 days. And my last update for you is I got a cell phone. So now you can call me anytime at 503-951-1760. That number again is 503-951-1760. Call, text. I like it when people say hi to me. All right. Now, I would like to introduce my money man. Dominic Ferrero is here to give you a fiscal update. Yes.
All right. Good morning, everybody. Not a ton of updates so far today, but I will share with the group that we're starting to see signed contracts come in. So if you did sign your PE46 contract, you should be receiving a payment hopefully soon. That payment was just processed. about 2 weeks ago, or approved 2 weeks ago. Please note that that payment is actually for 3 months, September, October, and November. So that will encompass 3 months of payment. So I think there was about 5 or 6 counties that got in for this round. And I think that's really all I have for today. Definitely welcome any questions that you have. And you know what? It might be relevant next time. I can add my information here so that they can contact me directly. So hopefully everybody has a good weekend. All right.
If you have any fiscal questions, feel free to type them in right now. Dominic is still here, but I will include his contact information in the outgoing email to you all. Sweet. We're about getting you your money. Thanks, Dominic. All right. So, community partnerships. If you haven't figured out by now, I am a storyteller. It's hard for me not to share my own experience around building community. So, for today's community partnership story, I'm going to tell you about the time I lived and worked in Southeast Alaska doing HIV case management. While I was living in Southeast Alaska, I had one client whose HIV status was revealed to his very small village. I worked then with the Alaska Tribal Health Consortium to connect with village elders. Our goal was simply to come to the village and do some HIV education with the entire community. It took us 3 visits over 4 months to finally get into the village to do the education. I was tasked with specifically doing education for all of the youth in the village. All in all, there was maybe 15 youth total. One method that we used in doing our education was to use more language and analogies this community could relate to. Hence the t-shirt shown here, use condom sense, spawn safely. They loved these shirts, and this is without a doubt the most memorable health outreach education I have ever done. I spent a lot of time on an island, only accessible by boat and plane. I saw humpback whales, and I ate bear sausage spaghetti for the first time. In some instances of outreach and education, I think it's important and, in fact, vital to stop what you're doing and just be a part of the community. This is especially true if you're trying to engage communities of color. Our sense of urgency is not that community's sense of urgency. And it was really important that we worked with tribal elders, getting their blessing first before we came in and did any education. In the end, this community was able to get the facts about HIV and that they could not get HIV from sharing a cup with this young man or breathing the same air. In the end, he was able to have a community to support him instead of continuing to live in fear and isolation. Community partnerships can look a lot of different ways, so I encourage you to, no matter what, meet people where they are. Be patient and know that you are doing important work that is much appreciated. Does anyone have any questions so far? Please type them in. As you know, I haven't figured out audio yet. No questions? Then we will move forward. And without further ado, I would like to introduce today's guest speaker, Miss Tessa Jacqua, ScreenWise Program Coordinator.
Good morning, everyone. As Dolly introduced me, my name is Tessa Jacqua, and I am the ScreenWise Program Coordinator. ScreenWise is a partner program that is located in the Adolescent Reproductive and Genetic Health section. So Dolly and I get to sit so close to each other and work together, and we are really lucky to be able to do this work together, but also we are a statewide program as well for breast and cervical cancer screening and diagnostics, as well as health systems work and general cancer prevention. Some of you may have heard of ScreenWise, some of you may have not heard of ScreenWise. We're going to try perhaps one more poll. I think some of you saw this one. So have you heard of ScreenWise? Yes or no? Weigh in if you can. And if not, we'll try and move on. We keep hoping it will work a little bit better. It wouldn't ever be a state webinar if we didn't have some technical difficulties. All right. Still having some difficulties. Let's move forward. So, what is ScreenWise? So as I said before, we are a statewide program. Many of you may have heard of us. Our program mission is to reduce disparities in breast, cervical, and hereditary cancer morbidity and mortality. Our program, although some of you may know us only as a service provider, actually works in two separate ways. So we secure access to clinical services via our ScreenWise provider network through disparity-driven service and also providing payment for services. And that is both through to providers who serve patients, but also providing payment for services for patients. And then we also work to promote statewide health system change through evidence-based intervention implementation. This is a little bit of a newer arm of our program. We have been working towards this for quite some time, and we are really happy to see the fruits of all of the labor from our partner clinics coming together to work as screening intervention partners through health systems in 3 different parts of the state right now. So ScreenWise really would like to focus both at the ask of our funders and at the focus of our statewide community on a few different populations. Rarely and never screened women, women or patients ages 50 and over for mammograms, communities of color, rural communities, women experiencing disabilities, and LGBTQ communities. Now, these are the ScreenWise priority populations, but they are not to be seen as populations to be screened in exclusion of anyone else. These are just the groups of folks that we want to make sure that we prioritize when we're doing outreach, and also for our clinics to think critically about how they are doing outreach to their own patient and community populations, kind of like PE46. So just a little bit of information around breast cancer incidence and mortality, and as well as cervical cancer. So while we do work to prevent cancer in totality at the state level, ScreenWise is specifically focused on breast and cervical cancer and how it impacts communities. On a national level, breast cancer incidence tends to be fairly high compared to other countries. You can see this data here, which is provided via Komen. You'll see that this breaks things down by per 100,000 women. So that has the case rate in the hundreds per 1,000 women for patients who are white and patients who are Black. And then you'll see the disparity that happens between incidence, which is on the left side of your screen, versus mortality. So you'll see that while the incidence kind of falls based on a race and ethnicity, you'll see that the mortality is skewed pretty heavily for different communities, specifically for Black women. So when we talk about priority populations, this is a lot of the data that comes in around focusing on communities of color, focusing on the intersections of disparity, things like disability, LGBTQ identification, etc. So this is breast cancer. When we look at cervical cancer, you'll see that some things stay a little bit the same. So people of color and Black women tend to still have higher rates of both incidence and definitely mortality. You'll see a little bit different on the cervical cancer incidence and mortality side that Hispanic women tend to have a much higher incidence rate and are also in the higher mortality rate than white women previous to breast cancer, which their incidence is a little bit lower. You'll see why that is more relevant when we get into the next few slides. Okay. In terms of, and I just wanted to give you another view kind of when we look at breast cancer incidence, and this is a different data source. So this is the Kaiser Family Foundation incident rates. You'll see that Oregon is kind of in the middle, a little bit on the mid to lower range. Individually, our incidence rate is about 118 cases per 100,000 women, and our mortality rate tends to be at around 21 cases per 100,000 women. So that's for breast cancer. You'll see that obviously there are pockets of higher incidence versus lower. This, and like I do want to point out that this data is from 2014, so it is a little bit outdated, but it's the most current data that we're getting on a national level with state comparisons. So for cervical cancer, once again, Oregon is kind of sitting a little bit at that mid to low range. So we do some things really well, but we do have a higher incidence among very specific populations, especially with cervical cancer. Specifically, it's our Latina and Latinx populations that tend to bear the brunt of cervical cancer, both on an incidence rate and a mortality rate. Our general incidence rate as a state tends to be 6 cases per 100,000, and our cancer mortality rate for cervical cancer tends to be at about 2 cases per 100,000. So, oh, yay, we had some answers. So what do you think is a bigger risk for your community? Breast cancer, cervical cancer, both or neither? So it sounds like we've had a couple people weighing in. I'm going to give folks a chance. So far, it kind of seems to be a consensus that both breast and cervical cancer tend to pose kind of an equal risk in the eyes of PE46 coordinators. I don't want to say I'm glad to hear that, because I don't ever want cancer to be a prominent risk for anyone. And that's our goal as public health professionals, is to kind of reduce those incidence and mortality rates. However, it's awesome to see that folks are thinking about this in a more broad spectrum way, and to see that you guys are going to be focused on both perhaps as a risk, and hopefully we can partner in the future, or you can get some great resources today. There we go. So when we talk about ScreenWise, so this is kind of, we're going to flash into a more, I don't want to say local, but hyper statewide kind of a view when we talk about demographics. ScreenWise as a program has been funded for almost 15 years. We are primarily funded by the Centers for Disease Control and the National Breast and Cervical Cancer Prevention and Detection grant. We are also funded by Komen and a couple of other smaller partners, and we also receive some state funding. We provide services all across the state. We currently have a network of providers that sits right around 208, including ancillary providers. We also work with partners all across the state, from community organizations to partners like 211 and Familia Sin Acción. and other culturally specific or community specific organizations that help get folks to services or help navigate them through the healthcare system. As a program, we see clients, and this is kind of an interesting breakdown of our clients. So we see primarily Latinx or Hispanic identifying clients. You'll see that these numbers are reported from 2017 through 2018. So this is about a year's worth of data. We saw about 4,800 Hispanic identifying clients. And then we also see a fair amount of American Indian Alaska Native in terms of population size. And then we have our other populations listed on the left. So we see a decent amount of Asian clients, and then we have folks who, when it says unknown and missing, it usually means that folks refuse to answer our question, which is completely fine. But we don't have the best demographic data, but I did want to give you a breakdown. This is a little bit different view of our racial and ethnic breakdown. This is compared to Oregon's racial and ethnic demographics. So ScreenWise clients are in the black, and Oregon population numbers are in the red. So you'll see that there's a pretty stark difference between who our program serves and the current population or demographic population of Oregon. A little bit relative to PE46 and also just to the work that we do, since Oregon is kind of a difficult state to serve when we talk about working with clients. We're a frontier state. We tend to be heavily rural. It's not always easy to get to the clients that we need, but the people who tend to do that work are our local public health departments and our smaller partners that, you know, span all the way into Grant County, Southern Oregon, Umatilla, all of our kind of far-reaching areas. We have this is our rural-urban residence breakdown, and this is based off data from the Office of Rural Health. And so we see that ScreenWise clients fall at about a 23% rural and a 78% urban. And that is comparative to Oregon residents at about 19 and 81. So we tend to serve a little bit more folks that identify as rural in terms of their zip code, and a little bit less in the urban, which probably doesn't feel like it when everything gets centered in Portland and we're here in Portland. But it's good to see that we're serving people out there. In terms of a breakdown of where we serve the most kind of rural clients, this is our county breakdown. I don't know if we have anybody specifically from these counties, but if you're on there, give us a shout out. We do see a lot of folks in Marion and Yamhill, and then we have kind of a breakdown into the 4s and 5s, which aren't represented here, mostly in Southern Oregon, a little bit farther down. And then I think we have about a 3 or 4% representation in Lynn and Benton County as well. So what is one word you think of when you think of breast and or cervical cancer? And this is a word cloud. HPV, that's a big one. Fear. Prevention. All right. Well, thanks for weighing in. Oh, we have another one. Screening. I love it. Treatable. Yes. Anyone else with a one word? It's really hard to break down such complicated things in one word sometimes. Support. That's awesome. Another prevention. I love seeing prevention right there. Another fear, fright, fear. There is a lot of that in communities around this and in the medical world too. All right. Thanks so much for weighing in. So it looks like prevention tends to be a huge focus when you all are thinking of breast and cervical cancer, which is I don't want to say there's a right or a wrong mindset here, but I think prevention is an awesome thing to focus on. And that's kind of what we're here to talk about. So in terms of screen-wise generally, so I want to do a little bit of a high level, a little bit of a more granular level, and this is when we're going to get into the more granular level. So in terms of screen-wise as a program, like I said, a lot of you probably know that Screenwise is a service provider, and we contract with providers, but we also have kind of different opportunities that are not just that. Obviously, you'll see on the left side, Screenwise enrolling providers. So our Screenwise enrolling providers determine patient eligibility. They enroll patients into our program. They conduct screening and diagnostics in some cases, and then refer out for other services as necessary. They collect and provide service documentation results, outcomes to our program via forms and reports. And then they also refer patients who are diagnosed with breast or cervical cancer to the Oregon Health Plan for treatment, or to other programs if folks are not eligible for the Medicaid expansion through the breast and cervical cancer treatment program. Providers can also participate with our program through health system change work. So health system change program work right now is kind of reflecting in using EHR data to access health systems, patient populations, selecting evidence-based interventions, so EBIs, from our community guide that we are tasked with from the CDC, and then kind of developing different quality improvement strategies to increase breast and cervical cancer screening across your patient population within your health system. So this is kind of outside of the spectrum of who's paying for what, and really about getting people the right screening as early as possible for their risk factors. So, and then we collect that data through some baseline data and then report it every year to the CDC. So these are kind of the two ways that Screenwise works with providers and also works with health systems and patients throughout Oregon. In terms of how we work with providers and what guidelines we recommend, we don't choose one guideline over another. We ask that our providers always utilize treatment-based guide or evidence-based treatment guidelines, excuse me. We primarily recommend the American Society for Colposcopy and Cervical Pathology, or ASCAP, the National Comprehensive Cancer Network for Genetics and Breast and Cervical Cancer Risk, that is NCNN, and then the United States Preventative Services Task Force, or USPSTF, as most people refer to it. These tend to be widely accepted guidelines and evidence-based treatment protocols, but they're not what everybody uses, but this is what we ask folks to use and tend to be highly respected. In terms of the services that we provide through our program, so this does tend to get a little bit confusing for folks. We do breast and cervical cancer screening services. So we do everything depending on age eligibility, from screening to diagnosis. And once a patient is diagnosed with cancer, then they need to be referred for the breast and cervical cancer treatment program, or to other resources for treatment. We only focus on breast and cervical cancer, as much as I wish we didn't have to focus on parts of people. That's our job. So we don't do uterine cancer, we don't do endometriosis, anything like that. So we mostly do the basic screening services, so mammography, biopsies, ultrasounds. We also provide some basic genetic counseling and testing as related to hereditary breast cancer, so BRCA, and then a couple of hours of counseling. And then for cervical, we do kind of standard processes, so pelvics, PAPs, HPV testing, and then abnormal follow-up procedures. So everything from screening to diagnosis, for the most part. And that's just the services we cover as a payer, not necessarily what we work with as health systems, but these tend to be widely accepted screening and diagnostic services. If you are a provider with us or you're familiar with our program, you will probably have heard a lot about our patient eligibility as it recently changed in May. This is just a breakdown of how a patient gets into our program as somebody who receives service coverage. So Screenwise patients, There's an age eligibility component. Age 21 to 49 are eligible for our services if they require diagnostics as directed by a provider. For folks age 50 and older, they are eligible for breast and cervical cancer screening and or diagnostics if needed. A patient must live or intend to live in Oregon. We do not do address verification, so we take it at a patient's word if they live here. Income, they have to have a household income at or below 250% of the federal poverty limit or level, excuse me. And then a patient must either have no health insurance at all or have health insurance that doesn't meet their needs. So these are typically high deductible plans or cost barriers, which cost barriers look very different to different people. Sometimes $5 copays are too much. So within reason, we will almost always enroll a patient if they have health insurance but not enough to cover their needs. And all of this information can also be found on our website, which we will list at the end of this presentation. In terms of the other opportunity that providers have for EBI implementation participation, so that's our health systems work. We work in collaboration with the Oregon Primary Care Association, or OPCA, and we invite health systems to promote evidence-based interventions, as I said before. So these tend to be things like provider recall or patient recall systems, or different types of small media campaigns to increase breast and cervical cancer screening services among patients, regardless of insurance type. So this work is really focused on making sure that we're not always focused on just who the payer is, but also who the patient is and what they need in order to make sure that early detection and prevention of cancers, and this focuses on breast and cervical cancer, but this can also be applied to any type of cancer prevention after this process, colon cancer, etc., is really just about getting people the right screening at the right time. We often find, and the CDC has done some research on this, that folks who have insurance, especially after the Medicaid expansion, tend to be a little bit forgotten in terms of how providers recommend services, because we kind of make an assumption, because we all are full of so much types of work, we tend to focus on folks who advocate for themselves, so folks who have good insurance, and then folks who have nothing. So we kind of focus at two ends of the spectrum, but then people who are in the middle oftentimes get kind of forgotten. So this is kind of a project that's meant to address folks at all stages of the spectrum of insurance coverage and screening and detection for cancer, breast and cervical cancer. So in terms of how health systems participate, like I said, health systems are invited through our partnership with OPCA. They are provided small grants for this work, typically between $5,000 to $8,000. And then systems can be ScreenWise providers. So we have worked with a couple of providers who are also ScreenWise provider, but it's not required. So you do not have to have a medical services agreement with us to participate as a partner in this work. And then health systems have to work to increase screening amongst all patients of screening age and need. So it's not work to just focus on one piece. Certainly you can do different types of evidence-based interventions to mobilize different parts of your communities, but it has to be a broad spectrum work. So who is in our clinical network? This is just kind of a broad overview. We have two types of providers within our network, both in terms of partners and in terms of what we see as ancillary providers. So we have enrolling providers. So these are the places where our patients get their initial services and who does the enrolling into the service arm of our project. These are also where our EBI or health system partners do their screening and preventative work. So these are federally qualified health centers, local health departments, rural health centers, private clinics, naturopaths, tribal health centers, and county clinics. Ancillary providers are our, I like to refer to them as our et ceteras. So our mammography facilities, imaging centers, surgeons, surgical centers, hospitals, genetic counselors, labs, all of the things that folks who have patients sitting in their offices and enrolling them can't typically do on site. So does your organization provide breast and cervical cancer screening and or diagnostics? Mostly yes, some not sure. All right. If your organization does provide breast and cervical cancer screening or diagnostic services, and you are interested in guidelines or partnership in any kind of way, I think for the most part, most of the people who are working with PE46 and working with Dolly are familiar with our program and are likely participating. But if not, feel free to reach out to me. My contact information will be at the end of the presentation. So why am I here talking about ScreenWise? What does breast and cervical cancer have to do with reproductive health? When we talk about reproductive health and specifically reproductive justice, and when we think about cancer, we think about, or at least I think about, disparity. Reproductive health access and breast and cervical cancer impact the same populations. It's part of the reason why I wanted to show you some of the data. We know that these are the people in our communities, and they're not relegated to only needing birth control or only needing a mammogram or a pap smear. These things go hand in hand. Cervical cancer prevention and detection, specifically, especially with our state population and knowing the disparity that happens, especially in our Latinx and Latina communities. When we think of things like birth control, pregnancy prevention, or achievement, cervical cancer is part of that service. You can disconnect the two things, but it's really best practice to really think about these things in a holistic manner. Providing care that addresses patients as a whole and not single issue, as much as we are just talking about specific body parts, which I wish we didn't do, but we have to. Holistic care is a best practice. So cancer prevention going hand in hand with reproductive health really is a best outcome for everyone. And access points, which you are working on creating, you are working on mobilizing, you are working with partnering with, for marginalized and medically underserved communities should really be as plentiful as possible for all things that could be possible. So cancer prevention, reproductive health, primary care services. And we know that service bundling helps outcomes, early detection, timely access, whether that's both to find cancer or to treat it. And if you are dedicating resources to increasing access, why not add cancer prevention too?
We have 2 questions for you.
Oh, there's questions. I'm excited. What are they, Dolly?
Are all health departments automatically considered enrolling providers?
Thanks for your question, Jolene. The answer is no. All health departments are not automatically considered enrolling providers. I would say for the most part, the majority of health departments are enrolling providers, but you must have a current medical services agreement with ScreenWise in order to be an enrolling provider. You also need to be onboarded to our program. Our program has undergone significant changes in the last, especially the last 2 years. So if you are interested to know whether you are a currently MSA'd, that's how we refer to medical services agreements, provider, you can feel free to contact myself, and I will, or you can look at our website and contact our screenwise.info at state.or.us email and to find out.
This is something our health department has not been doing for a very long time, but are most interested in.
I love to hear that people are interested in, and I would love to give a little plug. So there's a likelihood that a lot of your providers or your partners are currently MSA'd enrolling providers with us. That does not mean that they are active providers. Currently, we have, like I said, about into the 200s of providers in our network. In terms of active providers, I think we're at about 50. So certainly this is based on community need, and we did see a huge shift after the Medicaid expansion. However, with the constantly shifting world of healthcare and healthcare access, please, please, please contact us if you are interested in kind of renewing your enrolling partnership with our program. I will let you know that we are rolling out new forms as of January 1st, and our program, like I said, has undergone some pretty significant changes. I think they're all pretty good. So you'll want to kind of re-up your knowledge about ScreenWise and the services that we provide and the partnership that's possible. So if you're interested, like I said, my contact information will be at the end of this presentation, and I would love to hear from all of you. Any more questions, Dolly?
That's it for now.
Awesome. Let's move on. So in thinking about reproductive health access and access in general, in conjunction with cancer prevention, i.e. breast and cervical cancer prevention, I have put in some amazing, super cool data maps. I know Dolly was saying that she really wants to focus on data, and so this is kind of a way to dip your toes in it. I do want to credit not only the Oregon Rural Health Program, but also our amazing genetics and ScreenWise epidemiologist, Alicia Parkman, who put together all of these maps. So these are maps that are overlaid with the current ScreenWise sites. Well, data from 2015 over the current ScreenWise sites. So ScreenWise sites are labeled in the highest quintile. So this is a specific map for the percent of uninsured all incomes. So this is not necessarily relative to federal poverty limit. These are just folks who do not have insurance for women ages 50 to 64. So you'll see, as probably a lot of you would suspect, that rate of uninsurance goes up as you kind of get into more rural areas or more difficult to serve areas. So you'll see folks on the eastern side, you'll see some of the folks down in the south part of Oregon, and then you'll see a little bit of a pocket right around the coastal region in the middle section of Oregon, where we actually have a fair amount of providers. So you'll see too that there's a huge little cluster of green. I forgot you guys can see my mouse, so I can point at things. I'm so used to just talking via phone. I'm not used to the fancy webinars. So right here, you'll see, obviously, this is the Portland and kind of lower or upper mid-valley region. We do tend to have a lot of providers in that area. We do see a lot of patients from that area, but as you'll remember from the very, very early slides when we were talking about where we see most of our patients, we actually see the majority of our patients from areas here in the midsection of Oregon, specifically right around here. And then we do see a fair amount over here in the eastern part, and then up here close to Washington as well. So it's not necessarily to say that more clinics in an area means that we're only serving more patients in that area, and that does not mean that clinics in these areas can't engage more of the uninsured population. And that is primarily who our program serves or who works to serve and reduce disparity. When we think about uninsurance relative to federal poverty level, once again, this is the same age range, so 50 to 64, along with ScreenWise clinics. You'll see labeled, and you'll see that this map gets pretty significantly darker. So similar areas that you saw before, but not all the same in terms of how that level of uninsurance goes up really quickly, especially in some of the higher served areas. So when we think of income disparity as part of this, we really want to remember that that conjunction of uninsurance and poverty really means that our patients get put at risk, and we want to focus on getting them services, but also making sure that they have access as well. And when I talk about medically underserved, this is kind of a great way of thinking this. So this is the difference between medically underserved areas and medically underserved populations. So the areas are in the light kind of lavender color, and then medically underserved populations are in the blue. So and you'll see there's a definition right down here. So medically underserved areas are geographic areas without access to primary care services. i.e. breast and cervical cancer prevention or reproductive health. And then medically underserved populations are populations or subgroups who face a shortage of primary healthcare services due to economic, cultural, or linguistic barriers. So medically underserved populations can exist pretty much anywhere, even though they might not be a medically underserved area, and we see some of that here. So we'll see some overlayment in areas where there typically would be access, but for whatever reason, those listed, economic, cultural, or linguistic, these populations are at risk of medical underserving because of their population identification, not just the area they live in. But clearly, Oregon is facing a little bit of a crisis when we think about medically underserved areas. A lot of this map is that lovely little lavender color, and that's really where this work comes in, is that this is really about increasing access, and access is really about increasing access to services, which kind of will help reduce some of those things. So this is just another kind of helpful way of thinking about when we think about access. So this map highlights areas of unmet healthcare need. So this kind of looks at survey and population data that is relative to the needs of medical or the medical needs of communities all around Oregon. So percentage of primary care visits, ambulatory care conditions, all these kinds of things. So this could be access to hospitals, it could be access to primary care, it could be access to urgent care. So these are kind of the different need points throughout the map. And I wish I could have like a fancy overlayment of all these different maps and how they intersect. And we are actually working on that right now. But you'll see that a lot of the same areas keep coming up, specifically in the mid-range of Oregon and down in the southern areas of Oregon. So these are areas where we know we have populations, and I'm sure there are some of you on this webinar right now, and you are doing amazing work. But just know that the data backs you up in terms of knowing that your communities are at risk, or knowing that your communities are in need, and that we are here to help kind of maximize your resources so that your patients can get, your patients and your community can get as many services as possible. So, all of my jibber jabber, as Dolly would say, do you understand more about ScreenWise and the importance of breast and cervical cancer screening in your community? I like seeing the yeses. We can definitely get you more information, or you can always give me a call or send me an email. So here is my email address. I should have written down my phone number, and I didn't, but I will say it for you now. And I will repeat it multiple times. So my direct line, none of that menu business, is 971-673-1277. Once again, my direct phone line, that is to me, Tessa Jacqua, is 971-673-1277. You can give me a call, and if I can't answer your question, I will always forward you to somebody who will have more information than me, which is many of my colleagues. But and also, I believe, oh, it's after the questions. But on the last slide, there will be our website. But if you Google ScreenWise, we are the first thing that comes up. So that's a super easy way of finding us as well. Yes. Do folks have any more questions that I can answer about ScreenWise? Go ahead and type them in the chat box.
Thank you, Tessa. I will be contacting you.
Look forward to it. Anyone else? You can save it from my inbox too. That's really fine. Well, thank you so much for listening, and I look forward to talking with you or partnering with you in the future.
I can feel you all clapping at your desks for Tessa and the wonderful job she just did sharing information about ScreenWise. So we are still logged on if you have questions. Also, here's the ScreenWise website. Our sweet PE46 webpage, as well as the Reproductive Health Programs webpage. Here's my contact info with that fancy new cell phone number. Don't be a stranger. We'd love to hear from you. And lastly, our final PE46 webinar for 2018 will take place on Friday, December the 21st from 9 to 10 a.m. and will feature data. Thank you, everyone. Have a wonderful Friday.